So Sarah, when you are ready, you can start.
Thank you, Dr. Nader. Good afternoon, everyone. I hope you have a splendid weekend. So today, our agenda will be discussing about Dr. Nader will be talking with us about the geriatric medicine, and then afterwards, Dr. Ali Amin will be guiding us how to write an abstract, and then afterwards there will be a presentation on how to write a manuscript by me, and then Dr. Avinash will be presenting for us how to do the ERAS application. So I believe now we are ready. So Dr. Nader, when you're ready, please teach us about the geriatric medicine. Thanks.
Sounds good. Thank you so much, everyone. And so I'm going to give you a brief introduction about geriatric medicine. And the reason is we teach fellowship in 1 year. I cannot reduce the whole thing into 1 hour. Or half an hour or 15 minutes, but I'll give you the highlight about the geriatric medicine in a brief. There is an introduction to geriatric. That's I can share you some of the slides. If you look here, it's about 223 slides. I'm not gonna go over all of them, but basically, geriatric medicine is similar to pediatric medicine. In pediatric, we look at the children since they were born and then as they age. So we monitor their growth, we monitor their activity, they have milestones. Some of them have some diseases that we use, like vaccination, for instance. Sometimes they have syndromes, and we follow them until the age of 18. In geriatric, we reverse the same things, basically. So there is a cutoff age like 65 in the US. In other places, it might be different, maybe 60 or 65 again. So basically, what we need to do is to look at this older adults from different perspective. In primary care, usually we follow older adults, like in their 20s, 30s, 40s. And after that, with conditions, either we prevent conditions, let's say we focus on health, education, prevention, change of lifestyles, modification kind of to combat or prevent, let's say, heart disease or obesity. We encourage exercise, something in the primary care that we address. This usually done in family medicine practice or internal medicine, general medicine practice. In the geriatric part, we carry the same concepts, the same, we carry the same concept of prevention of certain conditions. So we give a vaccination in older adults, and we try to minimize risk of, let's say, falls, risk of other conditions, monitor with screening, like for cancer screening. And in addition to that, we carry the same follow, like the management of acute or chronic conditions, pneumonia, for instance, or hypertension, diabetes. The difference between the primary care in family medicine, internal medicine, and geriatric medicine is in the fundamental of we look at the whole person and the environment, the whole thing. So we look at the person and their environment or their social life, biological life, and all. And we approach that with a team approach. So it's not like a family doctor per se or with a nurse. We have the geriatrician, but most of the time we will have along with him or her, there is a nurse, there is a social worker, there is a dietitian, there is an activity personnel, And sometimes, if needed, they have physical therapy, occupational therapy, or speech and language therapy. So this is one of the main difference. The other difference is we look at the functionality of the person. So as we age, we tend to lose some of the function or some of the abilities to function. We get some impairment. It might be, let's say, you need glasses, eyeglasses, you need hearing aids if you have impairment of vision or impairment of the hearing. But also, if you have difficulty with walking, we ask you to use a cane, for instance, or a walker. If the progression of this impairment goes further, let's say walking, you are not able to walk, then we add the wheelchair. So all these are assistant devices that we use in geriatric. So by function, we look at how much can a person help himself or herself, and how much they need to accomplish the function that they want. For instance, feeding. As babies, we did not have the ability to feed ourselves. So mothers and families help with that, right? As we grow up, we are able to obtain that function. On the other end, as we get older, this function might be lost slowly. So you may be able to feed yourself, or you may be able to feed yourself, but you have trouble with dentures, with your teeth, and with swallowing. So you may need to modify your diet. If things go further, you may need help with feeding. If it goes further, you might have dysphagia and trouble swallowing and risk of aspiration. You may need feeding tube with certain conditions. So this is basically the function when we look at it. And when we talk about geriatric, basically we look at 5 of the main functions. You think about it, since morning, you wake up in your bed, and then for instance, I woke up, I went to the bathroom, I brushed my teeth, I changed my clothes, I came walking, let's say, to the kitchen, I ate my breakfast. So all these are functions that I'm doing in each day, basically. So this is called activity of daily living. Getting out of bed or getting into the bed, ambulation, you move around, taking care of yourself, all aspects, dressing, and then feeding. And there is another aspect of complex activity. It needs some processing, some planning. It's called instrumental activity of daily living. Let's say you want to make an appointment with your doctor for yourself. So the process is you have an illness, or you have a question, or you have concern. So you think about what the phone number for the doctor. So you grab your phone, you dial the phone, you talk to the staff there and find out what works for them, what works for you. You look at your schedule, you mark the appointment date, time. Then you think about who will help you if you need help, or how you going to attend that appointment. So you will basically arrange for ride if you cannot drive, or you can drive. So you find the address for that doctor. And if there is, let's say here in Michigan, there is snow, you need to make sure you have good condition, or at least you try to go early so that you prevent time waste in the traffic. All these are preparation or thinking in advance to achieve your goal. And this is called instrumental activity. and including, for instance, medication. You want to make sure you know how to handle your medication, you know how to follow the instructions. If you have issues, you want to raise these issues or concerns with your family members or with the care providers. So these are the big differences between what we do in geriatric and what we do in primary care as a family doctor or internal medicine. We teach you also in the fellowship in clinical different aspects of treating patients or doing prevention. There are some syndromes, geriatric syndromes, that we also go along and teach fellows in that sense. These syndromes are different. Fall, for example, falls is a big problem as we get older, using the stairs, light, snow, for instance, using certain shoes, wet floor, everything we need to think about when we're dealing with older people, so that we can prevent falls and injury as we get older. So this is the basic of the nutshell of geriatric. For you guys to get into a fellowship in geriatric, you need to first, as you did, complete your school in medicine. You finish training either in residency in family medicine or in internal medicine. And then after that, you apply for the fellowship. It's only 1 year. In certain places, it might be 2 years. When they are 2 years, usually there is a 1 year for research part. So you need to work on your project extensively in that program. One of the requirements in geriatric fellowship is you do some research project. It should be brief, not extensive, if it's 1 year. I think also in internal medicine, when we did that, it's required to do some research activity. Even if you want to just go to primary care, in the second year or third year, you should show them that you are able to conduct some research projects and finish your projects applying to conferences, for instance, or if you want to publish. And it will help you when you do other fellowship. One thing of the one benefit of the geriatric medicine fellowship is when you do it, if let's say you are interested in cardiology and you want to go to a very good institution. If you want to cardiology by itself, it's very competitive. And if you want to go to that place, it's going to be more competitive. So what I saw some people do is they do the geriatric fellowship and then apply to that institution on that program. It will raise your qualification compared to other applicant if you want to think about that. And as I said, it's 1 year and it will open your eyes to look at this population differently. The question with management in geriatric, the presentation might be atypical. Let's say a patient with pneumonia. Usually if the patient is young, in their 20s, 30s, or 40s, they will present with fever, cough, or shortness of breath. In older adults, the presentation might be with falls. So if a patient had multiple falls, you think about, hey, maybe there is an infection going on. You would do a chest X-ray, and here you go, you'll find pneumonia, for instance. For the medication, you need to look at the creatinine clearance and the mechanism of the medication that you want to prescribe. certain medications are contraindicated in older adults. Certain medication you can use, but with cautious, and then with cautions, and then also you want to monitor their renal function, for instance, or other function. The side effects might be common, so some might come with a condition, you treat that condition, they come again with the side effects, with other symptoms. Generally, we don't want to use a different medication to combat the side effects, although some of the physicians do that, so it will be a cascade problem, like you add one more medication, then the side effects come, then you add another one, and the list of the medication that patient use will be longer and longer. So the approach in geriatric, we want to limit the medication and de-prescribe or shorten that list of medication in older adults, and we will see if they really need them. Sometimes they need them briefly, let's say depression, they can get antidepressant, and if they can live with low dose of antidepressants, as well and good. And after a few months, we try to get rid of that medication and see if they can live without it. For instance, some do, some don't. It's just a trial. When we prescribe medication, we use the term start low dose and then go slowly. So you start with the lowest dose and build the dose up for your patient. So basically, this is what we do in a daily basis. So I think it took 15 minutes or 18 minutes. If you have questions, I'll be happy to answer any.
Thanks, Dr. Nader, for the great presentation. It has been very informative and eye-opening for us to know about geriatric medicine. I believe that Ali has a question. Please go ahead.
Hello, everyone. Thank you, Dr. Nader, for your valuable information. I have two questions. The first one about the clinical settings. Are they mainly outpatient clinics and nursing home facilities, or there are more of inpatient care, emergency visits, and so on? My second question is about what are the difference between applying as internal medicine resident or family medicine resident? Are they the same? Thank you.
Good questions. Thank you so much, Ali. So the settings, as a geriatrician, you will have similar to family medicine or internal medicine. So you can see your patient in the clinical outpatient setting. You can see your patient in a hospital, or you become a hospitalist, or you combine, or you can see your patient in nursing homes. So when we're talking about nursing homes, by the way, there is GRS teaching slides about nursing home in your app when you start in the introduction. There is some slides. If you won't have time, you can look at them. And below that, you can also go to the introduction if you want to get more information about the geriatric medicine. So these are two resources. So beside the hospital and the clinic or outpatient setting, as a geriatrician or as a family member, you can, a family doctor, you can go to the patient in their homes, or you can see them in an assisted living where they live in places where they get help, not 24 hours, but certain like for cleaning their bed sheets or providing them with meals, something like limited assistance, or in other setting like long-term nursing home settings. For instance, you can see patients there. Sometimes you see them in rehab where they have, let's say, they had a fall, went to the hospital, had surgery. They cannot go to their home. What they do, they go to the nursing home, the rehab section, where they do rehabilitation for a couple of months, when they are able to walk around and they are back to their baseline, then they go home. So you can follow them there. So it's kind of continuity of different setting. And depending on what you like, what your interests are, you can either focus on one setting or you can do as multiple things. When I started, I did multiple. I saw my patient in multiple settings. Currently, I'm limited only myself to rehab and long term. I used to go to patients in their homes. I stopped that. And nowadays with telemedicine, you can reach your patient any place, actually. The other question about the family medicine versus internal medicine, as far as applicant to the fellowship, there is no difference. We accept either or. And then the question will be what they will do next after that. And, that will also find the first answer. Good question.
Thanks, Dr. Nader, for a really great answer. I myself have a question. So,
Sure.
do as like geriatrics, are we involved in the emergency care of this population?
Excellent question. So, what you can do, you can, what we did at least when I started, we had a consult service at the hospital. So we had a geriatric consult, like cardiology consult or GI team. And then depending on what the condition, they call us and we see the patient. Mostly at the hospital, the patient might have delirium, confusion, they might be coming with dementia. So they ask us to evaluate patients with these conditions. And then we follow them and then they go either home or let's say go to rehab or nursing home. In certain hospital, a few years back, they started geriatric ER, which is a new concept at that time. So they divide the emergency room into regular beds where, like the pediatric, you have the pediatric population go to the pediatric ER section, and then the general population 18 to 65 or 55 somewhere, and they go to the general ER beds, and then there is a limited also number for patients who are older than 65. They go to the ER beds specifically for geriatric. So for these patients, the staff members, nursing or physician in the ER or the specialist like geriatric consult service, they provide the care for that patient. So they know how to handle this group of patients if they have delirium, if they have certain conditions that affect all the adults. So they are trained to take care of that group. And some of the hospitals, they went further, they assign one floor for geriatric. So the whole staff know how to handle patients in this group. Thank you.
Thanks, Dr. Nader, for answering the question. Please, Dr. Tigani, please share us your answer, your question. Sorry.
Assalamu alaikum, everyone. Thank you, everybody else. Just a quick, simple question. Since we're talking about majority of the pediatric, the geriatric population, they're resident nursing homes. So basically, as a geriatrician, how you do your follow-up visit with them? Mostly, as a geriatrician, you go to the nursing homes, or in private practice, their nursing home will send it to the geriatrician there, or how basically it works? Thank you so much for taking it.
That's a great question also. So each nursing home in this country is regulated very tightly by the regulation by the state and the federal. So one of these regulations is to offer clinical service to these patients. So as soon as the patient is admitted to a nursing home, they will be assigned to a physician as attending physician. This is number one. Number two, each facility, they have to have a medical director for the nursing home. So we have attending physicians who go to the nursing homes, and we have the program, the facility medical director that overshadow or take the whole care in perspective. So they have the care provided by their attending. Let's say patient X was admitted to the nursing home. They will call me as an attending physician that the patient came in. So my job is to review their chart, review their medication, make sure their home medication and the hospital medication are reconciled. There's no duplicate, there's no major changes that are not needed. And then we will talk about the plan, and then within the regulation, within 72 hours, I have to see the patient in person. With COVID, they allowed us to see the patient via telemedicine. After that, if they are going to stay in the nursing homes for a long time, then we are required to see them every 30 days. So 30 days, 60 days, 90 days. After that, it's every 2 months. If they are long-term, then we are required to see them every 2 months. In between this regular visit or regulated visit, you can see them as needed. So the nurse can call you after a week, say, hey, this patient have red eye, or they have fall or something. So you can go and assess the patient and change the plan accordingly. In certain, let's say, patient was admitted to the rehab. So what I do is I can see them every week in the rehab section because they are there for gaining the strength back and they want to go home, let's say. So if they change some of the medication at the hospital, most of the time we will keep this, and then as we go along, we change or modify it so that when they go home, they can use the same regimen or close something closer at home. For instance, at home, they were taking tablet for diabetes. When they go to the hospital, they don't like to put the patient on metformin or glucophage. They switch them to insulin. When they come to the rehab, and sometimes if the insulin is controlling their blood sugar, we will keep that. And then after a week, we will reassess and we will see if they can handle the metformin or glucophage or whatever oral medication again. And we will make this switch so that when they go home, they can be on the oral medication instead of the insulin and monitoring closely. Does it make sense for you?
Thank you, Dr. Nader. If not, anybody else had a question, I have another question, but I would leave the floor open for the others. If no, then I would add my second question. Thank you so much.
You're welcome.
Thanks, Dr. Nader and Dr. Tijani. I don't see anyone on queue for another question, so please go ahead.
All right, thank you, Dr. Saro. This is from relying on Dr. Nader's experience. To which extent do you think this population, geriatric population, are IMG friendly? You know what I mean? Baby boomers, racism, all this kind of issues can be a barrier between a care provider and the patients. To which extent do you think, or based on your lifetime experience, they're kind of willing to work with color, immigrant, somebody with accent, all this kind of, because this by itself can be a very challenging situation, which definitely affect the trust and the relation between the provider and the patient. Thank you so much for taking my two questions again.
Thank you. This is really also a great question, and I will compare it with what we are doing now, like the COVID vaccine. So it's very, very limited as far as my experience. I'm in the Midwest. I work here in Michigan, so it might be different in other places. But in general, I did not encounter any significant problem raise a problem or significant obvious problem. Perhaps there is some hint or some encounter where I can assume, but I cannot confirm that unless I talk to the staff and we all agree. And this will be similar to the side effects of one of the vaccines, Johnson & Johnson, 7 cases in 7 million, something, whatever. For me, maybe 1 or 2 cases in the whole population that I saw since I started in geriatric medicine. So they are very, very, very rare if confirmed. Again, it's just the conception. I did not encounter an actual verbal or physical or any like bias or because of my color of my how I talk or accent. I did not have limitation. Saying that, however, in the training or in talking to an older patient, I think there should be some skills that you need to learn, similar to, again, talking to a kid or the pediatric population. You don't use language with older, like someone in their 20s, 40s, you don't use that same with the kid. So for older adults, you need to watch how you talk and the manner you talk to that patient. So if they feel that you are respecting them, that's one thing. If they feel that you are treating them as if they are a member of your family, and sometimes I mentioned that in my first encounter, and will say, we are here to work with you as a team, and I will talk to the family member and tell them, I will treat my father like this, or I will treat if this is my mother, I will do this. So they will be looking at you at the same level without even we have differences in colors or accent or so. The other skills that you learn is when I talk, I try to talk slowly in small, simple sentences because of my accent. And I want to make sure they are acknowledging what I said. And then sometimes you think about their hearing, if they are using hearing aid or something. So you raise your voice if they cannot hear or if they have hearing impairment. What I do, I try to sit down on their eye level. Let's say they are in a wheelchair. When you are standing, there is a gap of a difference between you and the patient. So I try to sit down either on a chair or on my knees. Sometimes it's just depending on the situation. One thing I use is a touch when I'm listening, or when if you touch their shoulder, for instance, it makes a huge difference that you are caring about what they are saying. The body language when you're talking, listening to them, give them the space, the time to hear the whole story from their point of view. All this can start a very good communication between you and the patient or the family in that setting. So these are just tips I learned along the way. Thank you.
Thanks, Dr. Nader, for the answer, like highlighting how we communicate in an empathetic way and an effective way with our patients and their families. And thanks, Dr. Tijani, for your well-thought questions. Tamadr seems she has a question. Please go ahead.
Assalamu alaikum. Hello, everyone. I have a question. Like, there is a difference between rehab center and nursing home, or they are the same? And another question, for a geriatrician, there is a specialty after that? You become a GI, cardiology, or you need to refer them to the specialist?
So can you repeat the first question? I didn't hear it well. So
is there any difference between rehab center and nursing home, or they are the same?
Good question. In the past, nursing homes usually treat long-term patients with chronic conditions and limitation in physical activity, for instance, or dementia. But since, let's say, 2-3 decades ago, the payment for these nursing homes were not enough. So most, if not all, of the nursing homes, they have section where they have the rehab. The payment for a patient who comes through the rehab is much more, and it's rewarding for the nursing centers to cover the cost. So most of these centers they have a rehab section where they can cover their cost. Rehab patients, they will come, stay for short term, and then they go either home or assisted living. So I did not see a nursing home where it's only for long term. Could be there, but in my experience, I haven't. And I assume this is the reason. As far as rehab centers alone, that's an option where there is some certain rehab centers, and usually they are specific for conditions, let's say brain trauma. They can assign certain centers where they see patients with traumatic brain injury. They go there, they stay there, and then they go home, something like that. So this will be just for the rehab of that part. The other question, after you do the geriatric medicine, what else you can do? The door is open, actually. So as I said, let's say you want to do cardiology, then you finish your geriatric medicine, you go to do the fellowship in cardiology, then you will have 2 certificates or 2 accreditation. You will be a cardiologist in geriatric. If you want to do GI or if you want to do nephrology, then you will be doing both of them, finish the geriatric and then come to the nephrology fellowship, you finish that. And you can limit yourself to patients only in this population, or you can practice the whole subspecialty like cardiology or nephrology, oncology or other subspecialty. You can do as many. And vice versa. Actually, before I joined the fellowship, we had 2 physicians. One of them was a nephrologist for, let's say, 30-40 years, and he decided to do geriatric medicine. So he did the fellowship, and then he went and practiced geriatric. And we have another one who also practiced GI for quite a number of years, and then he wanted to take care of his parents who became elderly, so he did the fellowship in geriatric, and he was actually one of the faculty members. We worked together for some time before he retired, so it can be either way. One more thing, in certain programs like fellowship in geriatric, some they accept medical graduates, if they have some experience, let's say in UK or other places clinically, and they finish the steps, but they did not do the residency yet. So they can join the fellowship, they do the first year, 1 year, and then they can go back to do the residency, like backwards. I think Missouri, they have a program that like that. Here in Michigan, we had a program like that, but I heard that was closed, so I'm not sure if they're gonna open that again or not. So that these are good questions, Tomato. Thank you.
Thank you, Dr. Nader.
Thanks, Dr. Nader. Thanks, Tomato. Please, if you have any question or any input, please feel free to raise your virtual hand or write it in the chat. Otherwise, we can proceed with the next section on today's agenda?
Why don't I suggest to go to the next section, and if there is any question, just write it in the chat and we can address that, because I'm going to speak to you again later at the end of the meeting.
Okay, let's go ahead then. Thanks, Dr. Nader. Okay, so the next section or agenda will be presented by Dr. Ali Amin on how to abstract. So please, are you ready to go ahead?
You are muted.
Dr. Ali?
Yes.
Okay, so.
Hello, everyone.
Hi.
My voice is clear?
Yes, yes, it is.
Yeah. Okay. So, hello, everyone. My name is Dr. Ali Amin, and I'm happy to present a short review about how to write a research abstract. And it's about 30 slides. It's not too long. Sorry. Okay, do you see my screen?
No, we don't. No.
Do you see it?
Yes, it's now clear.
Okay. Okay. Okay, I will start by the definition of research abstract. An abstract is defined as a short summary of the research created to give a brief, not detailed description of the paper. So the abstracts are mainly created for the sake of quick review of the research topic. If someone is interested in certain topics, for example, a relation between a drug, a certain drug and a side effect, or a relation between a disease and a complication, instead of reading all research papers created on this topic, you can go over abstracts, short written abstracts in a shorter period of time, Then the abstract give you an idea about the paper, the whole paper. In case you find it related or relevant to your topic of interest, then you can go and revise the rest of the paper. So the main idea behind creating abstracts is that it saves times. It makes you it enables you to revise quick summaries about research papers without going into deep details in the whole research itself. So it is a short summary of the research created without going into deep details. But the abstract, despite that being not detailed and summarized part of the research, it should contain certain titles. Every abstract should contain these titles. The contents of typical abstract are: number one is a background statement or a problem statement. The background statement or the problem statement is the observation that makes the researcher, that pushes the researcher to create a theory or to create an idea that makes him deciding to study this theory. The background mainly about the observation that you may encounter during your medical practice, or you may encounter during your practice. This should be written separately under the title, a problem statement or a background statement. For example, as I have mentioned, a relationship between an association, for example, between a symptom and a condition, or a relationship between a drug and a side effect, and so on. Different observations you may encounter during your practice. You write this under the title, background statement. I will show you examples at the end of this session to make it clear, to make it more clear for you. The next title is objectives. Objectives of the research. Objectives are the theories to be confirmed or excluded. So you write that under the title objective, you write the theory that you need to confirm or you need to exclude. For example, this study is created to confirm the relationship between factor X, for example, and the disease X, for example, or disease Y, or a relationship between the drug X and the side effect and certain side effects. This is written under the title objectives of the research. Number three, the method. The method is the type of the study and the steps done to apply this type on the research. For example, this is a case control study. This is a cohort study. This is a randomized control study created by this step. Following these steps, amount of participants, the way of data collection, the method of data analysis, and so on. All these are written in more details in the research itself, but just a summary of the method should be written in the research abstract. The result is the study outcome in terms of figures and numbers. This is different from the conclusion. The conclusion is what are you going to apply in your medical practice, in your best practice. But the result is the outcome in terms of figures and numbers. The percentage of patients, the percentage of association of patients, or in whom the association observed, the percentage of the drugs, patient taking the drug and develop the complication, for example, and so on. So the results should be written in terms of figures and numbers. While number five, the conclusion should be written in terms of an implication or a recommendation in the medical practice. In the conclusion, you write that, yes, I concluded that there is an association between drug A and this side effect, or there is an association between the condition X, for example, and this side and this complication or this outcome. Generally speaking, any abstract should be clear that gives the reader a clear idea about the research without a need to go into deep details in the research paper itself. If the abstract failed to give you a clear idea about the research, this abstract is defective or it's not clear. It's not successful abstract. A successful abstract should be written in a way that gives clear, despite being not detailed, clear but summarized idea about the research. So as you are not in real need into going into the research paper, detailed research paper itself. Number two, it should be concise. Generally speaking, the abstract length shouldn't exceed 200 to 300 words. If it is less than 200, it's most probably defective. If it is more than 300, it's most probably redundant, or it contains too much details, which is not typical for a research abstract. And finally, the contents of the research abstract should be related to the main research material itself. So in the research abstract, you never present information that is not mentioned in the research paper itself. You don't bring another data from other researches and to present it in your abstract. Your abstract should be strictly related to your paper only, and it shouldn't contain information from other papers. This is an example of a paper I found on the internet. Effectiveness of amoxicillin clavulinate in the treatment of acute bacterial sinusitis in children. This is a paper done in 2009 and written in a pediatric book. In this paper, the research abstract is written as following. The background idea or the problem statement of this research paper was as following. Acute bacterial sinusitis is a bacterial infection of paranasal sinuses. Symptoms include fever, headache, and nasal discharge. Potential complications: preseptal cellulitis, orbital cellulitis, subperiosteal abscess, orbital abscess, and cavernous sinus septic thrombosis. So this is a background. In this background, we want to study in light of this background, or mentions the above background, we want to study the relationship between amoxicillin the effectiveness or the efficiency of amoxicillin clavulinate in treating acute bacterial sinusitis before the patient develops these complications. So what could be the objective? I want just this session to be some way interactive. So I will ask you some questions during the rest of this session. So just I will give you a time to think about the possible objective of this research. So the objective, yes, if anyone would like to answer.
It's to detect the effectiveness of amoxicillin clavulinic acid in treating sinusitis among pediatric population, like between age whatever, like
Yes, this is not exactly, but this is a good objective. This could be a good objective. Good answer, Sarah. Thank you so much. The research objective was to determine the effectiveness of high-dose amoxicillin clavulinate in the treatment of children diagnosed with acute bacterial sinusitis. So our objective was to determine whether amoxicillin clavulinate is effective or not in the treatment of acute bacterial sinusitis. The methods were a randomized, double-blinded, placebo-controlled study involving children from 1 year to 10 years old, diagnosed with acute bacterial sinusitis. So we brought children, or they brought children aged 1 year to 10 years, already diagnosed with acute bacterial sinusitis. I did not bring here figures because this is just a quick review, but they mentioned figures. They mentioned the number of children involved in the study. Percentage of those children were given placebo, and percentage of those children were given the amoxicillin clavulinate. And then they were followed for 14 days. Patients were randomly assigned to receive amoxicillin clavulinate, and patients given placebo. Then all patients were examined on day 14. And then the outcome was classified into cured, totally cured, or completely cured, improved, and no change, and cases cured, cases improved, cases with no change, according to a scoring rules based on the symptoms: fever, nasal congestion, frontal headache, and so on. Okay, the results were, of the 28 children who received the antibiotic, 50% were totally cured, 14% were improved, and 14% experienced no change. Of the 28 children who received the antibiotic, 50% totally cured, 14% were improved, and 14% experienced no change. Is it enough? Is it enough to conclude that amoxicillin clavulinate is effective in treatment of sinusitis? Any answer? It's not enough.
No.
Yes, you have to see the effect of amoxicillin clavulinate on patients. You have to see the effect of placebo on patients with acute bacterial sinusitis. Patients taking placebo, 18% improved and 68% experienced no change. So the conclusion, what could be the sentence? Yes.
Yeah, like we can, this is a cohort, so we can say the relative risk, we can compare the relative.
No, this is detailed. This is detailed conclusion. This is detailed conclusion. You write this in details in the research paper itself, but in the abstract, you just write an overall idea, a highlight about the conclusion. If there is relation or there is no relation.
Yeah,
so
we can say, yeah,
yes.
Patient took antibiotic, had better outcome in cure and improvement compared to the placebo group.
Exactly. And what would be your recommendation regarding the medical practice?
To use amoxicillin
clavulinate in treating acute bacterial sinusitis in children aged 1 year to 10 years. So this research confirms that amoxicillin clavulinate is effective in treatment of acute bacterial sinusitis more than placebo, or amoxicillin clavulinate results in significant cures of acute bacterial sinusitis more than placebo. Okay. Another example. This paper I participated in writing of this paper. I was not the main author. This is a senior doctor, Dr. Batul Ghurashi. She's a physician here in Sudan. But I was helping her when I was a house officer, an intern doctor. It's about the prevalence of diabetes mellitus and impaired glucose tolerance in patients with non-alcoholic fatty liver disease at Ibn Sina Hospital and Soba University Hospital in Khartoum. The background idea was that doctors there in Ibn Sina Hospital, they observed that many people with non-alcoholic fatty liver steatosis receives also a diagnosis of non-insulin dependent diabetes mellitus. So they created a theory that there is an association between non-insulin dependent, between non-alcoholic hepatic steatosis and non-insulin dependent diabetes mellitus. This is a theory. Then the objective will be, who will answer? Just give us what should be written under the title objective. Any answer?
To detect the prevalence of non-insulin dependent diabetes mellitus among patients with non-alcoholic hepatic steatosis in Ibn Sina Hospital during the time of
Exactly, certainly. Thank you so much. To study the prevalence of diabetes mellitus and impaired glucose tolerance in patients with non-alcoholic fatty liver disease among patients admitted at Ibn Sina Hospital and Sob University Hospital in Khartoum. The method was a cross-sectional hospital-based study. All individuals with sonographic evidence of fatty liver, but not already diagnosed with diabetes mellitus or hyperglycemia, were tested for glucose intolerance and for hemoglobin A1C. So they brought patients with sonographic evidence. They may have ultrasound scan for any other reason, for different reasons, ultrasound scan. But as a comment on their report, there was features of fatty liver. They called all these patients and they tested them for high hemoglobin A1C percentage and hyperglycemia or a poor glucose tolerance or glucose intolerance. The results were a total of 57 individuals were included in the study. 24 of them, which were 42.1% of them, had fasting blood glucose level more than 126. And 15% of them had 2 hours postprandial blood glucose level more than 200 milligram per deciliter. And so 24% had, this is the definition of diabetes mellitus, 24% of them had fasting blood glucose more than 126. And this is the definition of the diabetes mellitus. And 15% had 2 hours postprandial blood glucose level more than 200, which was the definition of impaired fasting glucose. So the conclusion was, what could be the conclusion here? Without going into deep details, the conclusion was this finding supports the concept that non-alcoholic fatty liver disease is an early manifestation of type 2 diabetes mellitus and may be helpful in setting preventive strategies for type 2 diabetes mellitus. And so Dr. Batur recommended, the main author recommended that every patient with non-alcoholic fatty liver should be screened for presence of diabetes mellitus and or impaired glucose tolerance. So her paper concluded that there is an association of non-alcoholic fatty liver disease with type 2 diabetes mellitus. And so, based in light of this conclusion, she recommended that every patient with non-alcoholic, even if it is incidental finding in ultrasound scan, it's better to screen them early on their life for type 2 diabetes mellitus. This could prevent years of poorly controlled diabetes mellitus, and this will result in reduction of complications of untreated or undiagnosed or uncovered type 2 diabetes mellitus. Finished presentation.
Thank you, Ali. The presentation has been great, very interactive, detailed, and supported with leading examples. So thank you so much for your effort in the presentation.
You are welcome. If you have questions.
Okay, so I think Hadil got the idea. So please go ahead, Hadil.
Yeah.
Hi everyone. I have a question about the abstract writing. Should be written in written in subtitles or in one paragraph? What do you think, Dr. Ali?
No,
Or both of way?
Okay. As I knew that, because I revised some abstracts written and approved in journals and papers. They were written in subtitles. They were written in one paper, but they were divided in titles. The first title, background statement. The second title, the method. The third title, the result. The fourth title, the conclusion. They're written in one paper, but in different titles, not in one paragraph.
Okay, thank you.
I can add that also.
Yeah,
it depends on that's a good presentation. Thank you so much, Ali. It depends on the publication or the journal that you are submitting to. So if you want, you can look at the author instructions, or you can look at previous abstracts, and it can be either this way or that way. There can be one paragraph, the whole thing,
Okay.
or it can be divided into the 4 section or paragraphs.
Okay.
Thank you.
Thank you so much.
Okay, thanks, Dr. Nader, for your valuable input. Thank you, Hadil and Ali, for your questions and answers. Please, Amina, go ahead.
Presentation. I actually have 2 questions. The first question is that when do you suggest we should start writing the abstract? Is it after we finish our study and write our results? And how much time did it take? The second question is that you heard that we should include another information from other researchers in the abstract. What is the background? Can we share information from other researchers to write the background or the introduction of the abstract?
Okay. As I found during my preparation for this presentation, it was mentioned many times that you shouldn't involve data from other researches. The abstract should strictly be related to your paper itself, because it's not a separate entity. It's not a separate part from your research. It's just a summary. It's just a highlight of your research itself. So the abstract shouldn't contain data or information from other researches. But inside the research itself, you can mention other papers done in the same field or in this topic of interest. But in the abstract, you should be strictly following what's written inside your paper. This is what I found, but what I found during my preparation. If there is any addition, it will be highly welcome. The other question is, please repeat it again.
When we should start writing the abstract?
Yes,
after
the last thing. Yes, exactly. The last thing. The abstract should be written after you finish all your work. Because you should write the conclusion and the result. So it's better to write the abstract after you finish all the work on your research. Then you write your abstract to include the result and the conclusion, which comes late during the study. Did I answer you?
Thank you.
You're welcome. Any addition? If there's any addition?
Dr. Nader, you're muted.
I think you did great, Ali. Thanks for your great answers. So I just want to, emphasize the abstract. When you write it, usually what happens is you come with the idea, you think about the methods, you work on getting the background, make sure your project is valid and can contribute to the literature. You start your work, you collect the data, analyze, and while you are writing your discussion part, you can also write, or after you are done, you can write your abstract. It's kind of condensing or summarizing the whole work into one page. The basic idea is to get it at the end. Thank you.
Good. Thank you, Dr. Nader. But ultimately, you will need to revise your abstract as you are revising your paper itself.
Correct. Yes.
Because the result and the conclusion comes late in the study. So until the last point before you submitting your research, you will need to revise your abstract again and again and again based on the result and the conclusion. Thank you so much.
Yes. Sounds
Yeah, thanks, Dr. Nader. Thanks, Ali and Amina. Shaima, do you have a question?
Thank you very much, Ali. It was really informative and interesting presentation. Thank you very much. So I think my question has been answered by Dr. Nader, but it was like, it is the same content for the presentations, for submissions, I mean.
I did not get your question, please.
So,
come again.
Okay.
I can give you an answer with
Okay.
two parts of it. One part is if you are writing your project to submit it as a manuscript for a paper for publication.
Yes, this is my question, exactly.
In that sense, yeah, so you can, as we said, you start your project, you work on getting the data, discussion part, and you already finished the introduction and background. After you did all this, you will write the summary of the whole thing, as Ali was mentioning, the abstract, and you can see what journal you are submitting to, follow the author instructions. They will give you how many word limitation for the abstract, what the titles or abstracts, and so forth. So after you meet the criteria, then you write your abstract. This is where you want to submit it to the paper along with your rest of the paper, manuscript, drafts, and whatever. The other part of it, you didn't ask about it. If you are only working to present your work as a poster, and we can talk about this in length in the coming meetings, then you will change that abstract into a format that can be presented in a poster where you will have your same, more or less, same headings that Ali was mentioning. You can add some of the references there, some acknowledgement there. So just to make it in a poster format. But yeah, thank you.
Thank you very much.
Thanks, Dr. Nader. Thanks, Shaima, for your question. Again, thanks, Ali, for a great presentation. If anybody doesn't have any questions or further input, I think we can proceed further for the next presentation. And if you have anything that comes across your mind, please share it on the chat or raise your hands at any time. So for now, I think the section is my presentation. So we'll be discussing how to write a manuscript. So I'll be sharing the screen now. Okay, so everybody can see my screen?
Yes.
Thank you. Okay, so it will be like it will not be like as interactive as Dr. Ali's, but it will be just a general framework how to write a research manuscript. So the main objectives for today is what are the components of the manuscript, how to write a good introduction, how to write the research method, and how to formulate the results, what to include in the discussion section, and writing the conclusion. So like as we see here, like it's just like a photo, like I'll be like dissecting it through the presentation. So we will be following the format that I usually know and I work with is the Imr D structure, which is like introduction, method, results, and discussion. And this is like how like it's also demonstrated in the photo. So how to write a good introduction. So the introduction includes like what's known and what's unknown and how and why like we are doing this research. So what's known about the problem and what do we know about it? Like it's usually a quick brief of the other studies. Like I know this information from these resources. And what's the gap of knowledge that I aim to examine and search for. The purpose and the objectives of our research is usually like it can be like a different, like separate structure, or can be included in the introduction. So the specific point I aim to search to fill this gap. The method is like, what did I do? Like how I'm gonna conduct the research. So what's the study design? Like, will it be a review of literature? Will it be a systematic review? Will it be a clinical trial? What's my inclusion and exclusion criteria? Like what kinds of study population I will be including, or what kinds of studies I will be reviewing that meet these specific criteria. How I am gonna collect the data, like are gonna be stored in Excel, Google Sheets, the data analysis, if we're gonna do like a couple of reviewers, will be doing them like independently, and how we are like reaching for the results, and what are the methods we usually follow to avoid like bias, or even like if we detect bias, is it common, something common. So like basically how we are the process of doing the research itself. How to formulate the results. So the results, like what we have reached so far through our study. It's totally objective section. We don't provide our opinions about it. It's the data we reach, regardless it supports our theory or not. So we indicate the number of studies we have reached, the demographics of the patients, the study population. If there are statistical mathematics we did, like if there are mean, standard deviation, if there's a median, if we are doing, if we calculated the odds ratio, the relative risk, all that is included. Usually for numbers, we tend to like approximate it to the 2 significant digits. And if it's a small study population, we usually prefer to like add like 1 out of 2, rather than like replacing this 50%, just giving the false illusion of doing like a huge study while the study population is very small. Usually figures, tables, and graphs that interpret the results are included in this section and referred to in this section. What do we include in the discussions? So in the discussion, like we see how do the findings relate to the original question we are aiming to, okay, that we have stated in the introduction. Does the data we've reached to support our theory or not? Like, for instance, like I want to know if, for example, vitamin D, does it have a benefit on brain cognition or not? Or my results like are not inclusive yet, and we need to do further research. Are your results of the study consistent with the other researchers? Are you getting along, or something different? And what is the difference you got? Is there any unexpected weakness in your study or any discrepancy of results, like as at the previous point? And this can be like a limitation of the study, like what were the main challenges? Will you be able to overcome them or not? And from that point, we need to know, like, do we need to do any additional research? Do we need to recommend additional research to answer the questions raised by the findings, and explain what's new about your research? How did you fill the gap, or did it fill your gap of question information or not? Writing the conclusions. Conclusion is basically a brief summary of the research question, the problems that we, and the effects and gaps, or the gaps we attempt to solve, highlighting the main findings reached in the discussion, and if there's any relevant research recommendations to be done in the future. Critical tips. First of all, like this is like how, like for myself, learned how to write a manuscript. Is usually I read the manuscripts as examples, leading examples, not just to copy and paste, just to get an idea how to reform and polish my writing style, my writing structure. And of course, key and golden rule to avoid plagiarism, like by all means, because it's our research, it's our effort. So we want to make sure it's authentic, not just like a mirroring of other people's work. We need to add references, like in text citations, and making a reference list. there's two citation tools have been useful, like EndNote 9x. This is the one that I personally use. The Zotero also is an interesting one. I hope to learn about it soon. And for publishing, there was like a question raised in the last time about publishing platforms. So just I thought maybe we can hint this in the presentation until another time in the future we can discuss it in details. Usually accepted abstracts for conferences usually are published in the journals related to this association. Like for instance, like the American Geriatric Society, the AMDA, if they accept our abstracts, they will be published in their journals. There's a website called curious.com. Its impact factor is 1.15, and the impact factor is the number of citations this website has. It's an open access, so it usually costs fees to publish. It's around this number is approximation around $300, but not more than that. Also, I believe one of our colleagues referred to this website in one of the previous sessions. There is a website called Gene Biomantics.org. It has like a good search engine for journals that are safe to publish, because unfortunately there are some journals like are scamming, like ask you to money for publishing and they don't. So this is a safe source, no journals, safe journals to publish. And of course, like our mentor also like can guide us which journal is more relevant and appropriate for our research study. And I hope this is helpful. This is again the diagram I followed to leading me to for this presentation. These are the resources that I referred to, I returned to make this presentation, and thank you so much. If you have any questions, please go ahead, and thank you.
Thank you so much, Sarah. That's a very great also presentation as Ali did. So both of you, thank you so much.
So if anybody has any questions in mind, please go ahead. Feel free to ask, or any input, further improve and help each other, share your experiences as well. This is more than welcome.
I just have a question for both of you and Dr. Nader about publications in journals. Like say, I was just checking, I have a study that I was looking to publish it, and I found that the prices, when I was looking to the like the sites for publication, the prices were extremely high. And I was just wondering, is there any like what are the possible like places that they have, like if we can just someone provide us a list, or I know I just saved the curious you mentioned, I have saved it to try it. $300 is fair enough. But if there are any other websites or places we can publish that they have like reasonable prices. Yeah, thank you.
Thanks for your question, Sarah. Well, my personal experience so far is like is through Curious, and we usually split the costs among the authors. Also, like I got a chance like to submit in the conferences, which were like out of cost, just like you have to be a member in the society. Other than that, I hope like Dr. Nader shares his input about that. Thanks.
Great, and this is a great question. So there are a few things. One, there are journals that accept your publication or your manuscript without fees if they have prescription or like these subscribers that have enough income for this journal. So if you have a good study, you can submit it to this free journal and they can accept that. There are these other journals also, they mostly web-based maybe, and they have other subscriptions, but they charge as Sarah mentioned. So it can start from low amount and it can go up to thousands of dollars. So there are a couple of ways to handle that. Either you divide the cost, as Sarah mentioned, between the authors. Sometimes if you are writing from the start before you start submitting, if it's a project, you put that in the funding part, that when you are searching for funds for your proposal, one section you write about how you're gonna publish your publication or the end result of your project. So you can search certain art journals and calculate the cost and mention it in your budget. The other way is to look at these journals. Some of them, they have, if you are, let's say in Sudan, you want to publish, they consider the rate is different according to what country you are from. It may have a lower cost or no cost if you are from developing countries compared to developed countries. So there are different ways to handle the cost. Thank you. That's a good question.
Thanks, Dr. Nader, for valuable input. Please, Sulafa, go ahead.
Hello, everyone.
Yeah.
Hi.
Yeah, so my question is, if you like to publish on like oral presentation, so how many reference I need for preparing for my research? Like, I know the article I might need 20 reference, but how many for the oral presentation? Thank you.
Thanks for your question, Sulafa. Well, my own personal perspective, and I didn't have like encounter problems in terms of minimum number of references. It's usually like if you want to do an oral presentation or like for abstract, like 9 references or 10 references will be fine. I have publications with around 19 or 18 references. You can go more as much as you would like to, but some journals prefer like a maximum number, like not to exceed. But like I didn't encounter a problem with a minimum number of references in any of my publications I have. But my experience is so limited. So I believe like if anybody has a better experience about that, like more encounter the problem in the terms of minimum number of references to be included, is more than welcome to step on the stage. Also, I hope Dr. Nader shares his input about this. Thank you.
So
Thank you.
thank you for the question, Slaf, and thank you, Sarah, for the answer. That's a great one. Again, if it's only oral, then let's say you are presenting using PowerPoint slides. What I usually recommend is you limit yourself to 1 page, 1 slide, if you can have your references there, as Sarah mentioned, 9, 10, maybe it's a good number there. If you want to go an extra, it depends on the topic. Maybe it's it's an important topic and it's current and you have a lot of interest in that topic and you found a lot of references, then maybe you can add another slide. So limitation maybe 2 slides with less than 20 in both of them. But if it's a simple oral presentation kind of, I think you should limit yourself to 1 slide with whatever references, like 9, 10 in that range. That would be great. Thank you.
Thank you. Thank you. That was so helpful.
Thanks, Dr. Nader. Thanks, Sulafa, for a great question. Okay, so if anybody has any other questions or input, please go ahead. Otherwise, I think we can step forward on the next section of our agenda today. So Dr. Avinash will be discussing with us how to write the ERAS application. So Avinash, please go ahead.
Hello, everyone.
Hi.
Hello. Today my topic is ERAS and how ERAS works. Let me share my screen. Do you see screen share seen to you?
No, not yet.
Do you all guys seen the screen?
No.
No. Wait a minute.
Okay, that sounds good. Now we can see it.
Okay, so the ERAS is stand for Electronic Residency Application Service, and how does it work? It is actually a third-party system, like students applying to the residency or fellowship program by using my ERAS account. And ERAS is going to take your application and send to the program directors, and the programs will receive the applications and documents for the review. The components of the ERAS, these are the 4 components. One is the My ERAS, in which you had to make your account. You can create your account. All of these, like the American medical graduates, DOs, IMGs, these all have to make the account and upload their assigning documents. And this is the Dean Office Workstation, which is mostly for the American medical graduates or DOs, in which the Dean Office send or upload their documents on the behalf of the students. While in my home country, this is not workable, because in the Asia, most of the documents are being uploaded by the student itself. And another is the program director workstation, which is reviewed by the program directors or programs. And another is the letter of recommendation portal. It is a portal in which you have to request to the supervisor, in which you are doing the observership or clerkship, and to tell them that request them about the upload of the letter of recommendations. So how does the ERAS application process? The applicants gather the supporting documents, all of these documents, and the applicants can apply to the program and send to the programs. And after that, they will get an interview, and after that, they may have to mesh process started. So this is the checklist of the ERAS, in which most important document is personal statement. After that, a letter of recommendations, and then the medical student performance evaluation, or the dean letter, which you had to take in from your universities or college, and request them to upload on the ERAS, or you can upload through the acfmd.org through the online applicant status and information system that we call as OSIS. And the medical school transcript, also same things. Either you can upload yourself, or your universities can upload it on the behalf of you. And the ACFMD status report and the USMD transcript will be issued by the My ERAS. You had to pay for this. And in the last, you have a good photograph for the applications. So the ERAS residency application start on means the applicants started to sending their application to the programs on the September 1, and the programs will review your application on the September 29. This is a timeline. On the June 9, the ERAS seasons open. You must have to buy token from the ecfmd.org on the September 1. We have to start applying the residency program to the whatever the either internal medicine or the surgery, in which all the, and on the September 29, the program directors will review your documents and send interviews. Hello.
ও তো প্র্যাকটিশনার মেডিসিন নেই, ও কিন্তু ওদের রিসার্চটা করতে হবে, নাহলে ধরো
on the March 14, the result will be announced, and 31st May the ERAS season closes. From this year, this is a new thing I have seen, that supplemental ERAS application for applicants applying to the internal medicine, dermatology, and general surgery in the ERAS 2022 season. ERAS is offering a new and a free supplemental application in addition to the My ERAS application for the applicant to share more information about themselves program. What is the role of this supplemental ERAS? That you had to provide the this basic information, your geographic information, the information about the most meaningful work like volunteer or the research experience, and the preferences signal. Programs from these three specialties like internal medicine, dermatology, and general surgery may require or encourage their applicants to complete this year's supplemental ERAS application. Okay, and this is the fees structure for the ERAS residency application. If you apply to the internal medicine, up to 10 programs, the application fees is $99. After the 11 to 20, $17 each program cost. After 21 to 30, each program cost for $21. And after 31 programs, each program cost of $26. This is the residency fees calculator from the website of the ERAS. You can use it. Okay, now the ERAS system work, how to register for my ERAS. You have to go to the link, the www.amc.org/my-ERAS. You have to create your account. You can get your token from the ecfmg.org and start your application from there. And also, after the ERAS token, you have to purchase a NRMP ID. NRMP ID is for the ranking system. And you have to upload your photo for the CV also through the ecfmg.org, not through the ERAS system. Update your CV throughout the year and make sure that whatever the experience you are writing over there, their description must be short and concise. So ERAS layout give us three experiences like the work experiences, research experiences, and volunteer experiences. In the work experiences, you can write down your all the paid opportunities you have had, either paid or unpaid opportunities. Write down the description, what was your role and what have you done in that work. Either you, what experiences you gain from that work. In the research experiences, you should list it by the project, capitalize your project titles, and write down your role in that project. What was the significant finding, impact, and paper presentation posters that have resulted from your work. And in the volunteer section, you can write down your experience in which you have done your volunteer in any organization. And a note on the publications, a publication section, I will share a next screen in which show you that how the publication segment seen, in which you have to write down your peer-reviewed or non-peer-reviewed. If you have done your research and you have submitted your research, either it is peer-reviewed or non-peer-reviewed, and either it is submitted or in preparation. You may list it submitted manuscript, but not manuscript in preparation. Okay? And if you have any oral presentation in any organization, you can put that information also. And the most important in the ERAS is the personal statement. You can use different personal statement for different specialties. And to customize your personal statement should consist of the information about your professional background, your academic and clinical qualification, why you pursue medicine, why you choose the specialty. Like if you choose the specialty internal medicine, you must justify that, why you choose as your career goal. So should reflect your personal statement should reflect the information about your personality and style that is relevant to the residency training in your selected specialty. Let me share another screen of the ERAS worksheet. This is the ERAS applicant worksheet, how the ERAS works. So in the first portion, dashboard, you had to write down your complete account information, name, first name, middle name, last name. And after that, you have to give your basic information, your preferred name, your preferred phone number on which the program's director can contact you. After that, we have an address, current mailing address. If you are living in the United States, you have to write down your United States address. If you are living outside US, you have to write down your home country address. Okay. Now the work authorization segment. Are you currently authorized to the work in the United States? If yes, then you have to justify what kind of your work authorization. Either you are a US citizen or legal permanent resident or refugee or asylee. So will you need a visa sponsorship? Yes, we need. Like we are IMGs, we need a visa sponsorship. What kind of visa sponsorship? We need H1B, J1. If you're done with step 3, you will require H1. Otherwise, if you haven't done with step 3, you have to require only J1, no H1B. This is the authorization work, US citizen, diplomat, A2, F1, which of the visa you have, you can write down over here. After that, NRMP ID, you have to purchase it and you have to write down here. And yes, participating as a couple in NRMP. Yes, no. If yes, then you have to write down your partner name and is your partner specialties in which programs they are applying, like internal medicine, general surgery. You have to write down your partner specialties over there. Urology match, it is not for us. If you are guys applying to the urology match, you can write down here and you can get another token for this match by separate token. This is your additional information. Write down your USMLE ID and NBOME ID is for the DO applicants, not for IMGs. This is also for the not for us. And if you are certified in advanced cardiovascular life support, you have to write yes. And what was the expiration date? You have to write over there. Sigma 5 status is only for the DO applicants, not for the IMGs. And Alpha and Gold Humanism also for the American medical graduates. Now the biographic information, either Middle East or Hispanics or Asian, you have to choose one. After that, in the language fluency, like if you are fluent in the English and multi-language, you can select more than one language. We have all kinds of languages here. Military information is not for us. Yes, the most important is the hobbies and interest. Make sure like you write down the true hobbies and interested, because the most of the program director will ask the questions from these hobbies and interest, and they will tell you describe all these interest. And like if you are love basketball or soccer, so you must know about these things. In the higher education, most of the IMGs do not write, but you can write down your secondary education in the entry 1, in the higher secondary education in the entry 2. Okay. In the medical education, you have to write down from which college or which institute you have been graduated. And in entry 2, if you have another degree like MPH or MBA, you can write down your whole information here. Additional information, like in the membership in the honorary or professional societies, like if you are an e-membership of the American Geriatric Society, you can write down in that segment. And in the medical school awards, during your medical school, if you have been awarded by the dean, you can write down here. And other awards are accomplishment, like any certificates or completion of the course from the online courses, you can write down in that segment. Now, the most important portion is experiences. Experiences, like if you are doing the training in the fellowship or the residency in your home country, you have to write down here what type of training are you doing. Like, are you doing residency or the fellowship? You have to write down here from which program, from which institute. And this type of experience is most important for the IMGs, in which experience type is required, either unpaid or paid, either clinical or teaching experiences. You have to write down either volunteer or the research or the observership. You have to write down all these things in here segments. And make sure your description must be concise and short and informative. Okay. Is there, was your medical education or training is interrupted? If yes, then you have to describe the reason why was it disrupted. In my home country, the MBBS is for 5 years without interruption. So write down no. This is the licensure portion. It is, if you have any state medical license, you can write down here. If you haven't, click on the none. Okay. This is the additional information like your medical license has been suspended, revoked, voluntarily terminated. No. Have you been named in a malpractice cases? Is there anything in the past you would limit your ability to be licensed or limit your ability? No. Misdemeanor in the United States, convicted felony in the United States? No. Okay, this is for the board certified. If you are board certified, yes, otherwise, no. Now this is the publication portion. The most important, like we are doing the research. Was your publication is a peer-reviewed journal article or abstract, or it is peer-reviewed journal article abstract other than published? We have more than this, like peer-reviewed book chapter, scientific monographs, other articles, poster presentations, and oral presentations. If you guys, any of these, you had to write down all the informations and submit it. Peer review online publications, non-peer review online publications, all these. And the last, you have to certify it, but make sure once you certified your applications, it will not go big. Thank you very much. This is all.
Thanks, Avinash. The presentation was very informative, detailed, and updated, and really dissecting the ERAS application itself. So thank you so much. I appreciate your effort. Thanks. I have 2 questions on the chat box. By Dr. Muhammad Ibrahim. So do we need to re-upload the MSPE Dean, like the Dean letter again, or we can still use the one from the last season?
Okay, so the good question, like this is my second application. So if you got any changes in your MSPE or Dean, so you had need to upload again. If you do, if you in your previous MSP and recent MSP do not have any changes, you do not need to upload it. You just get from your previous history.
Thank you so much. I second that as well. Like if you don't need to do any changes for the MSPE, we don't have to do anything, but make sure that you authorize if there's a step for authorization for
yeah, make sure that
MSPE
authorize.
Okay, the second question about the supplemental application for internal medicine.
Yeah, again, this is new for me. I researched a lot, but I couldn't find any much information from anywhere. So please give me a few days. If I will get any information for this, I will share with you guys. This is also new for me, and I need help in this.
I appreciate that, Avinash. Thank you. Okay, and okay, the second question is there a difference between uploading the Dean letter ourselves or make the Dean upload it?
No difference. Is there no any difference? But yes, like I said, like in my home country, our universities are not very helpful in this matter. So that's why we need to upload ourselves. Otherwise, it doesn't matter. If your Dean uploaded it on your behalf, that's good. Otherwise, you can upload yourself from the ACFMG.
Thank you, Avinash. Khulud is asking when we have to start make ERAS application worksheet.
Sorry, I couldn't get this question because can you elaborate this? Okay,
so I think Khulud's question is when should we start working on the application itself?
You can start from today. Like I just write down your all information over there and just save it in your account.
Yes, I agree. I can say from yesterday.
Yeah.
Okay, thank you, Khulud, for your question. Thank you, Avinash, for your answer. Thank you so much. From Lina, what about the AMC ID? If I am a second cycle applicant, will it be the same from the last year?
Yes, it will be same because I got my token a few days back and I got my same AMC ID. So yes, this is same, but your token was different. So you need to purchase your token.
I second that. Thank you, Avinash. So we usually it's the same number, but just like we have to pay the money. That's it. And do we need to update the date of the LOR that we had from the last season?
Well, if you, the answer of this that you cannot update the date of LOR. Like if your supervisor put the date on that LOR in the 2019 or 2020, that will show to the same. If you want to change the date, you need to upload again. So you can request to the supervisor to upload in the renewal date. Okay.
I second that. Avinash,
Second
like,
that.
yeah. So like, if you want to update the letter, like the dates, I think we can update the date of signature of the
Yes.
attending himself. So you can reach back to him, like send them emails and ask them that you are applying this year for a second time.
Yes.
And just like you will update the signature date, but you cannot like change the date of the rotations.
Again, but again, my question is that does it matter? Like I done my observership in the 2019, okay, and my date was that in the 2019, and I imported all of these LOR. If I'm going to request my supervisor again to upload it in the new date, but the period of that observership is remain same. So does it matter?
I heard about the 1 year window.
1 year window, yeah.
But I haven't I don't know. I haven't maybe like some people having I've seen people having rotations like 2 years ago. Like I have like close friends who apply, he did rotations for
So
instance
it's
in 2014.
good. So it's good. Do not use old observership LOR. You have to need the new LOR for the recent application. That's the answer of this. Like if I'm going to apply in this season, I will send them a new LOR, not the old one.
Yes.
Okay. Yes. If I haven't any new LOR, then I can share a previous LOR to them, to the program director.
What is still amenable for update after submitting the application? So let me just answer the question. It's just like the personal information. We cannot do any kind of changes in the application once we submit it. Once we certify, even if you certified, I don't submit it, you can do any changes.
Yeah.
So can you elaborate on the visa? Which one with step 3? So there's a multiple choice question. Oh yeah, okay. So like Khaled answered. So it's the H1B visa for step 3, takers.
Yeah, like 1 year ago in my first applications, I haven't been done with my step 3, so I applied for only J1 applications. But now I'm done with the step 3, so I am eligible for the H1B also. So if you haven't done with your step 3, you can apply for the H1B also.
Thank you, Avinash. Another question, what's the last date I can give step 3 so I am eligible for H1B visa?
Well, that's a good question. You can done with your step 3 as soon as possible, but you have a window period up to the November. Like if you get your exam in the November and you get your result in the December, and if you get the interview, you can tell to the program director like I'm done with the step 3 and I'm waiting for the result. So they will consider you even up to the March. One of my friend, he got an interview in the February or January, and one of the program directors said to him like, I will give you H1 visa once you're done with step 3. And he did his step 3 in just 2 weeks and got his step 3 result in a 3 week, and emailed to the program director like, I'm done with the step 3. And the program director converted your visa from J1 to H1.
So impressive. Very a good example to follow. We hope we can do that. Thank you so much, Avinash, for your answers. That's it for now. Like to see no more questions, but actually I'm curious about Dr. Nader's input about the ERAS application and how we can like further formulate it and polish it to make us like more desired candidates for the residency programs.
Excellent. Thank you so much, Dr. Avinash, for the great,
Welcome.
helpful presentation. And it's very detailed, which is good. I hope that will help everyone at least to start the process. And if you have questions in next week or so, you can ask Avinash again.
Sure.
To improve the application, I think I can share with the screen with you here. What I did with the fellows in last year who successfully accepted to the programs, business program last year, I asked them to share their applications with me. So it will be used for you as an example. So if you go to the app here, you scroll down, you will see the ERAS application samples. If you click on it, it will take you to this screen where there's 4 samples actually. So I hope that will be of help for you guys to look at an example actual, and you can modify and write your own experiences as far as clinical and any other certification, any other courses or publications, something like that. You can know how to do it the right way. But there are different ways to improve the application itself. Maybe next week someone can get some tips and share with us about how to improve the application. I'm thinking of one idea is, if I think I'm sure all of you English speakers and English and Spanish share a lot of common words, and some words, if you add an O, English word will be a Spanish word. So to have you label yourself as Spanish speaker, I think it can be easily done. But if you want, you can practice a little bit every week to gain the basics of the Spanish language. And you can focus only on the body parts and the system part of the clinical aspect, and then the interview part where you can use it if you encounter a patient who speaks only Spanish. In real life, you will have a translator during the encounter. It's required, but at least you will have the report or rapport with the patient, and they feel better when you can at least say a couple of words in Spanish. And it's the second language in this country, so I think it will have a good weight on your application if you mention that. And you can say as a beginner. So this one tip, but some of you next week, if you will, maybe you can add more tips and skills to add to the application. Why don't you just look at these examples and see if you want to modify your application as we go along. And we can talk also later from each one of you who has different experiences or their friends who matched last year. And then next we can tackle beside the application the personal statement, because it's also important how to write that in a good format that can be attractive. Thank you.
Thank you so much, Dr. Nader. I appreciate that, the examples and your input about the Spanish learning. I think is very important because like the Hispanic population is very representable percentage here in the US. I think Khalid has a question. Please go ahead.
Yes, my question is regarding the new supplemental application. I've also saw that they ask about your most meaningful work. So I think your most meaningful work would already be in the ERAS application. So Does any one of you know if I'm going to repeat this information again in the supplemental application or not? Or maybe just mention it there and go more in depth about it?
Okay, thank you, Khalid, for your question. It's a very good question indeed, and I think it's very important for all of us to know about it. But it's very new for everyone here. So we need to do further research and further reading about how the process works and what are the programs applying for it. So I can promise you, like, I can do my research here, and if I get a link of information about that, I can share it on the group, on the WhatsApp group, so that we can help each other, like, about it. But as mentioned earlier, like, it's very new information for everyone, and we need to, like, read and help each other in terms for the supplemental application. I'm sorry you couldn't have much about that. Dr. Nader, would you like to share an input about this idea? Seems Nader.
Dr. Nader left.
Okay, he will try. I think there's a problem with his connection.
I had a technical issue here, sorry.
Okay, thanks. Welcome back. So just we've been curious about your input in terms for the supplemental application for this year.
Avinash, can you answer that question?
Actually, I got an email from the ERAS 1 week ago, and I searched it on their website, but I couldn't find any more information other than these 2 pages. Like they will announce, even they are not sure yet. They will announce in the first week of August. Until I couldn't find any more information on their website. As soon as I get information, I will share with you guys. But yeah, it is only for the 3. It is only for the 3 programs: internal medicine, dermatology, and general surgery.
Excellent.
Okay, thanks, Dr. Nader. Thanks, Avinash. I think we all have, like, our share of homework about this.
Yes, exactly.
So if anybody has any information, notice any information about this, please share it with everyone. Okay, to be very appreciated. Dr. Tigani, please go ahead.
Yes, thank you, Dr. Nadir, Avinash, Sarah. I just had a quick question. I'm not sure if that's only my internet connection or something wrong with the file itself. I tried to click into the samples, but the link is not working. Experiencing some kind of thunderstorm here. Just might be my internet. If anybody else have the same issue, maybe there's a way it can get fixed, hopefully. Thank you.
Thank you, Dr. Tigani, for your observation. We appreciate that. I think I tried also to get access to the samples as well, and I couldn't get access. Like, it sends me directly to the email sharing option. So I will appreciate Dr. Nader if you can take care of this. Thank you. Okay, so does anybody has any other questions in terms of ERAS, or should we proceed with another section in the agenda? Okay, so now we just like to have a quick brief about how the projects we're working on have become so far. So I would like just quickly to just update everyone about the research for the preventive measures for healthy aging. So our team, we're a team of 11 people, and we managed to dissect the topic because it's a very broad topic, like it has so many dimensions. So we focused during the past 2 weeks on 2 elements, were cognitive exercises, and we specified that with music and vitamin D, and its relation to a cognitive function while we age. We managed to finish the abstracts. We finished and submit them with the conferences for the American Medical Association. Now our team is working on the other 2 elements, the sleep and the physical activity and joint health elements. So we are again splitting ourselves in like into like a smaller team than the previous ones, just trying to collect the elements to make one full manuscript about this, and we aim to publish it, be ready for publication and for Dr. Ned's review, and then approval for publication by end of August. This is in terms for our ongoing project. If anyone would like to share their updates about their projects, please go ahead. Sounds good. For my team, I wish I could expand it, but because we have a limit number of authors and we don't want anybody to work to be involved in the research, and then we have a problem with the number of authorship. So like we feel like it will not be fair for that person. So just want to make sure that we have a number that everybody, when they participate, they are included in the authorship, and there's like no limitation or somebody had to be excluded after their tremendous efforts. But if we get to work on other projects, I will keep you updated. Thank you, Dr. Tigani, for your question. Baba, you have something to share? Please go ahead.
Assalamu alaikum. Thank you so much, Sarah, for the opportunity and great presentations, all of you, very informative, really enjoyable, great work team. I just want to share the update regarding COVID. Hopefully next weekend meeting, we will not talk about COVID webinar anymore. So we finally finalized the date for the live. It's going to be on the 10th. We had some difficulties and delays on announcing it, so that's why we pushed it a few days ahead to spread the word. And from this point, I want you guys to share. I sent it to the WhatsApp group earlier, the announcement and the flyer. Try your best to share it. Unfortunately, for the US-based fellows, it's going to be a weekday midday, but I will encourage you guys with your lunch hour, if you're working, to join us and be like supportive of the team. And also in Sudan, encourage your relative in Sudan to attend it. I found that it's like around Maghrib time, so it's good with the tea and Maghrib tea to enjoy us talking about a little bit of information. But this is regarding COVID, and thank you so much for your work of spreading the survey. We had really very informative responses and answers. In regard to dementia, I apologize. I haven't reached to the team yet, but in my mind, I had the same deadline as the other project or manuscript, end of August. Hopefully, at least we will write in the application that we submitted somewhere. So I will try my best to reach, maybe not before Tuesday, but after Tuesday to reach to the team and determine a time to meet, or at least discuss through the WhatsApp group. So far, those are the two projects that I feel like are urgent at the time being, and that's all for the update, but great presentation. I really enjoyed. Thank you so much.
Thank you, Lubaba. We're looking forward to the webinar and hope things go smoothly from now on. Thank you so much. So if anybody has anything you'd like to share with us, or we step forward to the next section. Okay, so I think we have one final section about how we can remove duplicates. So I think there was one question by Abir last week, and Dr. Nader suggested that he can lead us today about this. Thank you. So Dr. Nader, you're muted. Sorry.
Thank you so much, Dr. Sarah and Dr. Lubaba, for the update. So for the detecting or identifying the duplicate, there are different ways, but I'm going to show you in Google Sheet how to do it, and there is a way to do it also similarly in Excel sheet. So the idea is one thing you can do is here you can turn on and off filter. So you can highlight all your data if you click on the box here, or if you want to highlight only one element or one column, you can do that here, and you can sort it or you can filter it. So I'm going to do just the filter for the all, and it will be on. If you click it again, it will be off. And what that help you is you can sort. Let's say if you want to click here, you can sort your data alphabetically A to Z or backwards. You can sort by colors if you color them and so on, and you can search for certain things here. But for the purpose of identifying only the duplicate, let's say we have the current fellows and putting their first name, last name. I want to identify how many duplicate names here. I can sort them alphabetically, the same here, and it will list, so I can look them manually. That's tedious and long way to do it. The other way is to do what we use formula. So I'm going to just show you how to do that here. So if I click on this empty cell here, I can write unique. It's a formula, or it's Google Sheet syntax where it will calculate things according to what I need. So unique is one command, and then it will ask for the range. So I want only the first name to be a range where I want to identify only the unique. So it will just remove any duplicates. And then these are optional information. And if you click on enter, it will list all the names only once. So it will remove the duplicates here. This is one way of, if you want to clean your data, for instance, quick way. So just equal, unique, and you open the parentheses, put the column for yourself. The other way to do it, if you want to look at what duplicates we have, you can go and highlight your column, let's say A, and go to format. And if you want, you can say conditional formatting here. When you click it, it will open a new dialog sheet or box. It will be on this side. Here you can add a formula where you can identify. Sorry, so you can customize the formula here also, and you can add whatever you want here. In this part, I can just show you a different way. Let's say I want to look at only the countries. So the column C, I can highlight and I can write the same formula here, unique column C, and then it will limit only the names for the countries, for instance. The formula here, you can add it and it will show some of the, let me grab that for you. So I don't have it right now, but okay. I don't have it up, so I don't want to waste your time. But basically, there is a formula you can add here to identify the duplicates for yourself. I think in SPSS, there is a way also similar to unique, and you can identify the duplicates and remove it. A third way to do it is you go to your browser, let's say Chrome, and you can add an extension where it will identify the duplicate. You can add it. It's like a small program in the browser where it will just add the data and then identify which column you want to see the duplicate, and it will highlight that for you. So there's different ways of doing it. I hope this is helpful, but if you don't practice it, it will not make sense, a lot of sense. So this is just the basic idea. Thank you.
Thank you, Dr. Nader. I appreciate that. We definitely need a lot of practice with the Excel and how to remove the duplicates. Thank you so much. I just have a question. So what's the name of the extension we can add to the Google? You're muted.
Okay, you can search for duplicate. Let's say duplicate removal. There are a couple of extensions that you can add.
Thank you so much, Dr. Nader. Thanks. So I believe it's this is the last section in today's agenda. So I believe we'll be proceeding forward for arranging for the next week's one. Thank you.
Thank you. We can work on the next week agenda. Yes, I found the formula, so you can add the formula. So let's say if I want to see if there is names here duplicate, I can just add the formula. Conditional formatting. Here. And this is the formula. So count if, and it will highlight which names or which data you want to identify as duplicate. So let's go over the next week agenda. Any suggestions? I think Tamador will be moderating the Zoom meeting, and the Purple team, if you can, this is suggestions again, if one can show us how to search PubMed, for instance, and another one can talk about how to prepare or get ready for poster presentation. Next part is ERAS application improvement. Is like tips or tricks or any skills to improve our ERAS application. And maybe someone can talk about a personal statement. And then if another one can teach us about the PowerPoint coach, how to present using the skills that are available using PowerPoint online. And update of current or new ideas about the research projects. Any suggestions or any thing you want to modify, please let me know.
Yeah, it is good agenda for next meeting. I create a WhatsApp group for Purple team. If one, please join, and we can arrange for that. Thank you.
Thank you.
Hello, everyone. I'm Dr. Nader. Actually, I tried to reach Dr. Tamador before, and I would like to communicate with her to join her WhatsApp group because I'm one of Purple team and recently joined.
I put the link in the group, but I will send it again.
Okay, thank you. Preferably through email or like that if it's difficult.
So I checked the Tamador email on the chat. Sarah, if you want to copy that and communicate with her. Thank you.
Thank you.
Okay. Thank you, Dr. Nader. It's shared with me.
Oh, sorry.
Okay.
Sarah, yeah.
Yeah,
You can share it with the group.
yeah.
I did it.
Okay, thank you so much.
Any other questions, any other suggestions for the agenda?
Okay, so I think if, okay, Amina, please go ahead.
I have a suggestion that if we can have a presentation about how to search for the teacher review. If I have, for example, if I have an idea how to search for teacher review regarding similar researches or articles.
I think this is what the web PubMed will be presented next week about how you, let's say you have an idea or you have a project and you want to see if it's already mentioned there. So you want to look how to search for it on the PubMed website. And there are other machines or data sets you can use. One of them is Google Scholar. But for now, let's focus on PubMed. It's a government data set or database where all the publications are sitting there. So you want to search by, let's say, keywords or by topics or by authors or by whatever year, language, something like that. So if someone can teach us how to do that next week, that would be great. And I hope you will find the answer there.
Okay, thank you, Dr. Nader, for the great answer. Thanks, Amina, for the question. So just to confirm, final calling for any questions or anything anyone would like to share. Okay, so let's wrap up for today. It has been wonderful to be like moderating today's meeting. Thank you so much, Dr. Nader. Thanks for the Brown team and thanks for everyone who shared their point of view and their questions. They were very valuable. Appreciate. I wish you all a wonderful weekend and thank you all.
Thank you, everyone. Thank you, Sarah, for the moderating, and it's great Zoom meeting. Thank you so much. Hopefully, this will help you guys, and for those who did not join us, hopefully you can look at the recorded video. Have a nice weekend. See you next week. Bye-bye.
Thank you. Assalamu alaikum.
Thank you. Good job, Sarah. Next week.
Thank you, Baba.
Thank you.
Thank you.
Assalamu alaikum.
Thank you.
Abu Zar, if you still there.